بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما يا كريم. اللهم اجعلنا ممن يستمعون القول فيتبعون أحسنه وأدخلنا برحمتك في عبادك الصالحين. Dear colleagues, we'll discuss a new topic in brain imaging, which will deal with the value of diffusion brain imaging by MRI. To start with, we have to know some of the terminologies that are used whenever we are interpreting the diffusion weighted images in order to understand what do we mean by this. You know that we have two types of motions in the human body of the cells. The motion which is directed, like that occurring in the blood vessels, this is known as directed motion, while another motion which occurs in any direction or in different directions at the same time, this is known as the Brownian motion, or known as isotropic motion. Then diffusion means that the something is spreading widely through a certain medium. The diffusion coefficient means that the rate or equals the rate of diffusion in this tissue according the type of the tissue. Like an example, if you put a drop of ink in water and you wait for some time, you see that ink is diffusing somewhat through the water. But if you wait more time, then you can see that the ink is almost homogeneously distributed through the water. What is the relation between the diffusion of ink in water and the imaging of the brain tissue? You know that the brain tissue is formed of cells and the extracellular space which contains water or fluids. And by diffusion, or the aim of the diffusion weighted images, is to measure the movement of extracellular fluid, the movement of the fluids in between the cells. And because this movement is random and is obstructed by to some extent by the presence of cells, glial tissue, and the membranes, this motion is known as anisotropic motion or anisotropy. And we have the diffusion, which measures the movement of the extracellular fluids in the brain tissue. What is the diffusion coefficient? It is the determination of the rate of diffusion of these fluids, and because we cannot calculate the diffusion in a random way, so the diffusion coefficient whenever we are dealing with the brain tissue will be known as apparent diffusion coefficient, which is equal to the sum of motion in the three-dimensional planes. Then diffusion weighted MR imaging is based on the detection of the motion of water in the extracellular space, as I have mentioned. In order to calculate or determine the motion or the diffusion of water in the extracellular space, we have to apply two gradient pulses to the normal pulse sequence, which is known as the 90 and 180 degrees pulse. What is the value of these two pulse gradients in imaging? Let us uh, uh, let us try to calculate the speed of these runners. In order to know who is faster, then you have to arrange the runners along a line of the start. Then you give the signal to move. Then at a certain time, then you can say that this one is faster and this one is less, and so on. And this is the value exactly of the pulse gradient. The first pulse is used to arrange the protons, let us say, in a line. And the second pulse will measure the movement of the protons. Then, if you have two pulses, and this is the first pulse and this is the second pulse, the first pulse will arrange the moving protons so that in the second pulse you can calculate the motion of these protons. Then let us look for this example. We started, let us say, by 3 protons, and in the second pulse we identified all the 3 protons giving very high signal. Then you know that there is no diffusion in this area. Starting by 3, they are now 2, and this is minimal diffusion. Starting by 3, and they are 1. This is moderate diffusion. Starting by 3, and you detected none of the protons in the second pulse, and hence there is no signal, then you got free diffusion. That is to say, in the diffusion weighted image, whenever the diffusion is restricted, then you got high signal. If the diffusion is free and you got no signal, or let us say iso-intense or a slightly hypo-intense signal, then increased signal means restricted diffusion. No signal in the diffusion weighted image means there is free diffusion. Then what are the causes of diffusion restriction? There are actually 3. Number 1, the cells are swollen, so the extracellular space is reduced and the motion of water is restricted. The cells are increased. In some tumors, there are too many cells and the extracellular space is minimal. The viscosity of fluids is increased. The cells are of the same number, there is good extracellular space, but the fluids are increased in the viscosity. And these are the 3 causes of diffusion restriction. Then small molecules will diffuse rapidly, and you got no signal, meaning diffusion free. Large molecules will diffuse very slowly, and you got increase in signal, which means there is diffusion restriction. Then this p-value, which is one of the pathognomonic figures of diffusion imaging. What is the p-value? You know that the gradient strength is constant. This gradient is constant, and the time between the time of the each gradient is also constant. Then the p-value represents the time between the start of the first pulse, which will arrange the protons, and the start of the second pulse, which is used to calculate the rate of diffusion. Then, if the p-value is 0, meaning that you apply the first pulse and immediately you applied the second pulse, then you got just a T2 weighted image because you didn't allow any time for the water to diffuse. But if the B is in the range of 500, then you give some time to calculate diffusion. If it is 1000, then you give more time, exactly like the ink in water. Then, what is the ADC, or the adjusted diffusion, the apparent diffusion coefficient? This apparent diffusion is known as apparent because you cannot calculate actually the diffusion rate through this anisotropic motion, which is random in every direction and obstructed by too many ways. But this image is calculated by the computer. Then the computer will have the sum of signal in different images obtained with different b values. You start by b0, which is exactly t2, and you may obtain images at b100, b200, b300, and so on. Then the computer will look at these images and start to calculate the apparent diffusion coefficient. In cases of diffusion restriction, then there is no motion and there is no signal. Then in the ADC image, you got the site of the lesion. If there is diffusion restriction, the site of the lesion will be black, like this. This is the diffusion weighted image, and the lesion will appear bright because the protons are still, the motion of the protons is restricted, and you got high signal. In the ADC, whenever the computer tries to calculate the rate of motion in different directions, and you got no signal in the area. Then if you see high signal in the diffusion weighted image and low signal in the ADC map, then you are dealing with diffusion restriction. Then sometimes you can see high signal in the diffusion weighted image and also high signal in the ADC, and this is known as T2 shine through. This will occur in lesions where they have very bright T2 signal, like simple cyst, for example, the hemangioma, another example. Then the diffusion weighted image will not be able to mask the lesion totally, exactly like a light behind the curtain. If the light is weak, then the curtain will obstruct the light totally. If not, then you still see some light in spite of the presence of the curtain, and this is what we call T2 shine through. So if you see a lesion which is bright in the diffusion weighted image and the black in the ADC, and this is restricted diffusion. The opposite, you see the lesion which is black in the diffusion weighted image and bright in the ADC, and this is diffusion free or facilitated diffusion. If the lesion is bright in both images, and this is T2 shine through. And this is an example of T2 shine through. The lesion is bright in the diffusion weighted image and is also bright in the ADC map. Then what are the values of diffusion weighted image? Number one is differentiation of acute from chronic stroke, differentiation of acute stroke from other lesions, differentiation between epidermoid and arachnoid cyst. I have mentioned this many times before, and differentiation between abscess and necrotic tumor. I will show some examples. Differentiation of encephalitis from gliomas, where in encephalitis the diffusion will be restricted. Assessment of the full extent of diffuse axonal injury. In diffuse axonal injury, the CT may be free at all, but we have many techniques to see the lesions. Then what's said nowadays is it is used in the grading of gliomas and also the differentiation between types of meningiomas, and this is actually under study. Then we start by one of the important issues of or important values of diffusion imaging, which is the brain ischemia. As you all know that the ischemic brain tissue will show diffusion restriction because during the ischemic insult there is disturbance of the the flow of water between the intracellular and the extracellular spaces. And there is a gradient which leads to the diffusion of water from the extracellular space to the intracellular and the opposite. Ischemia will lead to disturbance of this mechanism and water will go inside the cell. This will result in two issues. Number one, the cell will swollen, and the swelling of the cell will decrease the extracellular space. Number two, the extracellular water will decrease. Then by logic, you know that there should be diffusion restriction. And at that time, where the cells are swollen and the extracellular space is limited, you hardly see any changes in the CT and the MR images. But in diffusion weighted images, you will see the area of restricted diffusion, denoting that this is a hyperacute or an acute insult. Then, ischemia will lead to movement of water from extracellular space into the cells. This happens without increasing the total water content of the area. At that time, the T2 weighted image will appear normal. But after the cell is swollen, it will rupture. Then you got, this is the mechanism, you see extracellular water, intracellular, and then the extracellular water will go inside the cell will swollen, and the extracellular water is decreased. Then after that, the cell will rupture, and the water will come outside the cell. At that time, you can see high T2 signal and high flare signal, and this is known as cytotoxic edema. Cytotoxic edema, which will appear of high signal in the T2 and the flare images. Then MRI per se cannot usually differentiate vasogenic from cytotoxic edema, but the diffusion weighted image can differentiate vasogenic from cytotoxic edema, because vasogenic edema will show diffusion free, and the cytotoxic edema will show diffusion restriction. Then on diffusion MRI weighted images, we should look to the ADC map in order to know whether the high signal in the diffusion weighted images is due to restriction or due to the T2 shines through. Then look here, if you look carefully to this image and you see in the right insula, you see some signal void vessels, which are the branches of the middle cerebral artery. If you look carefully here, you don't see such branches on the left side, and this is not enough for the diagnosis of ischemia. But in the diffusion weighted image, and you can see that there is a big area of diffusion restriction, which represents the hyperacute infarction. And diffusion weighted images and the ADC map will show the ischemic brain tissue within about 30 minutes up to 2 hours after the symptoms. And you remember that other imaging modalities, CT may take about 24 hours, and MRI may take a longer time than 2 hours to show the abnormality. At that time, which between half an hour and 2 hours, no abnormalities seen on MRI and CT. The signal of acute stroke is increasing due to the first week after symptoms and decrease after that. Then the ADC will, in ADC the lesion will appear black, and the ADC values will decline rapidly after the onset of ischemia and start to increase from dark to bright within 7 to 10 days. At that time, the infarction is turning from acute to subacute and the chronic phases. Then If you look here, and this is the CT scan, the FLAIR weighted image, and this is the fusion weighted images of a patient with acute right-sided infarction. In the CT scan, you can see very minimal hypodensity here, and also you can see subtle high signal in the right side, but the diffusion weighted image can show clearly the appearance of the infarction, and this phenomena is known as flare diffusion mismatch. Also here, another example of flare diffusion mismatch. In this flare image, you can hardly see this lesion, but the lesion is quite bright in the diffusion weighted images. And in all patients, you know that due to subcortical arteriosclerotic changes, and you got too many bright lesions around the ventricles in the white matter in both T2 and the FLAIR images. And if the patient had an acute insult at that time, you are not able by routine MRI to separate the old lesions from the recent lesions. Then in diffusion weighted images, this is the FLAIR image, and see bright foci bilateral in the white matter. And in the diffusion weighted images, all the chronic lesions will not appear in the diffusion weighted image, but the acute one will be shown here. This is the site of the lesion. And also here, both CT and MRI FLAIR image show extensive white matter abnormalities in both cerebral hemispheres. And the diffusion weighted image showed the acute insult, which is located in this area. And this is the cause of the symptoms for this particular patient if there is a recent complaint. And this is the CT scan, this is the EDC, and this is diffusion weighted image. In the CT, you see hypodensities in the temporal area and also posteriorly. You can see here good part in the frontal lobe and part in the parietal lobe, but the recent of these is this area, which shows diffusion restriction, bright in the diffusion weighted image and black in the EDC map. Then restricted diffusion with acute ischemia is seen, as I have mentioned, in about 30 minutes up to 2 hours in the affected area. Restricted diffusion is markedly hyper intense on DWIs. The ADC continue to decrease and is reduced at most at this time 8 to 32 hours. The ADC remains markedly reduced black um, for about 3 to 5 days, and after that the diffusion is elevated as a result of increase in the extracellular water and the tissue cavitation and the gliosis, meaning that after about 3 to 5 or up to 10 days, and you got some change in the infarction from the acute phase to the subacute and the chronic phases. Then may free diffusion may show a slight hypointensity on DWI, isointensity or hyperintensity, and in this situation, the T2 shines through. And you remember that in DWI, the acute lesion or the um, the chronic lesion or with free diffusion will show usually hypointensity on DWI, and maybe isointensity so that you cannot see it at all, or maybe hyperintense if this is the T2 shine through phenomenon. Then this is a chronic infarction in an area of encephalomalacia with a vasodilatation of the ventricle, is low signal in the T1, high signal in the T2, and low signal in DWI and high signal in the ADC map. Then sometimes you got reversibility of ischemic lesions, and this is well known in cases of posterior reversible encephalopathy, for example. And the lesions with diffusion restriction may not progress to complete infarction, and sometimes you got reversible changes, and the lesion will not continue to the full-blown picture of ischemia. Then, few patients may show complete reversal of diffusion bright lesions. I will show you some of this. And false negative results in diffusion weighted images are reported in these patients. Patients with very small brainstem infarction, the infarction will not appear in the diffusion weighted images showing restriction, because this area is very much disturbed by artifacts. Deep gray matter nuclei infarction in this area may also not be seen, and areas of decreased perfusion which later progress to an infarction, meaning that when in the starting ischemia there is an ischemic tissue and an area surrounding known as the penumbra, which shows some decreased perfusion but is not yet an ischemic. Then these areas may not be seen in the diffusion weighted images. And this is the diffusion weighted image, and this is the follow-up after 3 days, and you got reversibility of this lesion. The lesion appeared here, and after 3 days it is not shown, meaning that it has been reversed. Then conventional CT and MRI are not reliable for detection of acute infarction. Diffusion weighted images are very sensitive in detection of hyperacute infarction before the changes in the T2 and the FLAIR images, and also in the acute infarctions. These are the reported sensitivity and the specificity of diffusion weighted images for detection of acute lesions. Lesions with decreased diffusion, a lesion with diffuse decrease is strongly correlated with a reversible infarction, but sometimes you got reversible lesions. Acute neurological deficits suggestive of a stroke without a lesion means that you got no diffusion restriction on DWI, include the transient ischemic attacks, peripheral vertigo, migraine and seizures, intracerebral hemorrhage, dementia and functional disorders, amyloid angiopathy, and metabolic disorders. Then non-ischemic syndromes, no abnormality on MRI, no abnormality on DWI, and reversible clinical deficits may be seen in the previously mentioned lesions. Now we came to an issue, which is a lesion that is particularly seen in the splenium of the corpus callosum. And this lesion is hardly detected on the T1. It may show some bright signal in the T2 and the FLAIR images. If you inject contrast, the lesion will not enhance and it will show diffusion restriction. What is the diagnostic value of this lesion? This lesion is known as transient lesion of the splenium in the splenium of the corpus callosum. Occasionally seen on MRI, and may be small, maybe in small in size and large, and may be due to one of these etiologies, like epileptic patients, patients with demyelination, multiple sclerosis, acute demyelinating encephalomyelitis, posterior reversible encephalopathy syndrome, and a lot of underlying conditions. Then this lesion is transient, it will regress, and we have two distinct patterns, a small one and a little bit extensive lesion, which will involve the corpus callosum as well as the adjacent part of the cerebral hemispheres. The literature say that the small lesion is typical in the setting of seizures and cessation of anti-epileptic drugs, meaning that if patient is epileptic and you perform an MRI you may find this lesion in the splenium of the corpus callosum, or after the stoppage of the anti-epileptic drugs, and you can see this lesion, which is, as I have mentioned, a reversible lesion, and the MRI will return to normal within 1 month. And if you are confronted by an epileptic patient and you see this lesion, which is hardly seen in the T1, very faintly seen in the T2, with diffusion restriction, bright and deep WI, and black in the ADC, and you know that this is a transient lesion in the corpus callosum, in the splenium of the corpus callosum, that is seen in many conditions, and just you wait for a maximum 1 month and this lesion will disappear spontaneously. But if you see a lesion that is more large, like this one, and this lesion is an infarction due to thrombosis of the straight sinus. And this infarction is seen in the CT scan and also seen in MRI, the FLAIR image, and the T2 weighted image, with the classic diffusion restriction. Then a small lesion is usually related to seizures and anti-epileptic drugs, while larger lesions are usually related to the one of the lesions that are listed previously. In posterior reversible encephalopathy syndrome, you got bilateral, almost symmetrical lesions in the posterior aspects of the brain and in the posterior fossa as well. These lesions are hypointense in the T1, hyperintense in the T2 and the FLAIR images with free diffusion. Syndromes with potentially reversible vasogenic edema, as the previous example, are seen in eclampsia, which is one of the causes of posterior reversible encephalopathy syndrome, hypertensive encephalopathy, and cyclosporin toxicity, other posterior leukoencephalopathies, venous thrombosis, HIV encephalopathy, and so on. Then infarction, whether it is in the watershed area, the area between vascular territories, or in the vascular territory itself, will show the same. It will appear of low signal in the T1, high in the T2 and the FLAIR with restricted diffusion if it is an acute infarction. And there are some modern concepts about the difference between the ischemic area and the surrounding area with decreased perfusion, what's known as the area at risk or the penumbra. Then what is the role here? You see that in the acute state, and this is the diffusion weighted images showing a small lesion in the left temporal lobe. But in the follow-up diffusion weighted image, and you got the lesion is more large because there there was an area at risk in this particular area, which is shown by perfusion imaging, and this area will develop will be ischemic or develop an infarction after some time. And this what we call the diffusion perfusion mismatch. Diffusion perfusion mismatch means that there is a lesion in the diffusion weighted images which does not correlate with the perfusion weighted images. Either the DWI show a bigger lesion or a smaller lesion, or there is no lesion in the diffusion weighted images, and it is seen in the perfusion weighted images. And here, what we call the diffusion perfusion mismatch, this is the infarcted area or the infarction core, and the surrounding area, which is the hypoperfused area, and what we call the penumbra or the area at risk. If you look here, and you can see that the area of restricted diffusion is very small. but the area of uh, decreased perfusion is too big. And you can see that there is almost no flow in the middle cerebral artery. And this is the ischemic core, which is seen in the diffusion weighted images, and this is the penumbra, which is very big compared to what is seen in the diffusion weighted image. Then this statement is very valuable. The previous trials of thrombolysis based on perfusion diffusion mismatch failed to prove any value, meaning that if you see that there is an ischemic area here, but the perfusion map showed that the lesion is very big. And based on this finding, you start to do maneuvers to save this area and to limit the ischemia to this particular area seen on the diffusion weighted images. The literature said that there is no significant value from these trials. Then we came to the intracerebral hemorrhage, and sometimes they said that whenever you are dealing with hemorrhage, which is clearly seen by CT and also by MRI, the diffusion weighted images will disturb your interpretation. And you can see here this statement, which is good also. Some of the hemorrhages will appear very black or very dark on the T2 weighted image. Like, for example, the hyperacute blood, the acute blood and the early subacute blood will appear black on T2 weighted images. And you expect that the T2 shines through will the opposite of it, which is the T2 blackout effect will occur in such hematomas. And you got the hematoma dark in the diffusion weighted images and also dark in the ADC map. And if you look here, and this is hemorrhage in the right temporal lobe, then let us forget about this image, and you can see here that there is an area of restricted diffusion, bright in the DWI and the dark in the ADC, and you say that this is an infarction. But if you go back to the CT or even MRI, then you see that this is a hemorrhage. And this explains what I have said, that diffusion weighted images in cases of hemorrhage may disturb your interpretation. And this is the gradient image, which is very sensitive to blood. And this is the flare image, and this is the diffusion weighted image. Another example of a subdural hematoma. In the T2 weighted image, the hematoma is bright. In the diffusion weighted images, the hematoma is bright, and in the ADC map, there is restricted diffusion. And if you forget about this image and you interpret this maybe as an infarction, then diffusion weighted images play an important role in the differentiation or the discrimination between some types of the tumors. Most of the tumors will show free diffusion, black in the DWI and bright in the ADC map. But some of the lesions will show diffusion restriction, and this will depend on very much on the cellularity. The tumors with a cellular matrix will have a little extracellular space, and the movement of water will be restricted. The tumors which are known with prominent cellularity are the lymphoma, medulloblastoma, and the primitive neuroectodermal tumors. Then, and you see here that there is a lesion in the frontal lobe on the left side, and this lesion showed heterogeneous enhancement, which is diagnostic of a glioma. And the diffusion weighted images, it will appear black, and in the ADC map, it will show bright signal, meaning that it has a diffusion facilitated or facilitated diffusion. And this is the case of a brainstem glioma. A bright signal in the T2 weighted image with the characteristic phytic extension along the basilar artery. And in the DWI, the lesion is black. In the ADC, the lesion is bright, equals free diffusion. Most of the brain tumors will show free diffusion. Then the medulloblastoma, which, as I have mentioned, have a prominent cellularity. The medulloblastoma appears of little bit bright signal in the T2 and also in the flare. If you inject contrast, it will enhance. But in the diffusion weighted image, you see very bright signal, meaning that there is restricted diffusion. And it is said in the literature that medulloblastoma is the only lesion which show diffusion restriction in the posterior fossa tumors. Then lymphoma is also one of the cellular lesions, cellular tumors, and enhanced image, it shows almost homogeneous enhancement, bright in DWI and the black in the ADC equals diffusion restriction. And this is also another case of lymphoma. The lesion is not so much enhancing in the contrast enhanced image, but it appears of bright, relative bright signal in the T2 and prominent diffusion restriction, bright in the DWI and black in the ADC map. Another case of the lymphoma by CT and diffusion weighted image, the lesion is bright. In the ADC, the lesion is black, meaning that it has restricted diffusion. A case of brainstem glioma, low signal in the T1, high signal in the flare, marginal of enhancement of non-uniform thickness in T1 post contrast, and almost free diffusion in the DWI. Meningiomas are also one of the tumors known to have high cellularity. Then you expect that some types of meningiomas will appear with restricted diffusion, and this is an example. Convexity meningioma, low signal, almost low signal in the T1, and homogeneous post-contrast enhancement with characteristic dural tail, and the diffusion weighted image, you got bright signal, and the ADC, you got low signal, meaning that you are dealing with lesion with restricted diffusion. Another case of meningioma, convexity meningioma on the left side, T1 and flare, then T2 weighted image, and T1 post contrast, homogeneous enhancement, diffusion weighted image, restricted diffusion. Then one of the importance of diffusion weighted images is to differentiate between an abscess and a marginally enhancing tumor. And you know that abscess will show restricted diffusion, like this one with marginal enhancement, bright signal in the DWI, and low signal in the ADC, meaning that there is restricted diffusion. But in cases of glioblastoma multiforme, which may appear exactly similar to an abscess in the contrast enhanced T1 weighted image, but in the ADC you got black lesion, and in the DWI you got low signal, and the ADC you got high signal, meaning that there is free diffusion. And this is an abscess with restricted diffusion. This is the flare image, the T2 weighted image, T1 post contrast, marginal enhancement, DWI, very bright signal, meaning that there is restricted diffusion. The same applies to encephalitis, meningitis, subdural empyema, epidural empyema. All these inflammatory lesions will show restricted diffusion, and this is an example of multiple subdural empyemas by T1 post contrast with marginal enhancement of the subdural collections, and these collections appeared with restricted diffusion in the DWI images. Also, in cases of herpes encephalitis, if the lesions are subtle, they are not well demonstrated in the T2 and the flare images, and the lesion is seen here, but it will appear much brighter in the diffusion weighted images because of the restricted diffusion. And this is an example of encephalitis, flare image and diffusion weighted images. And here you appreciate the lesions that are well prominent in the diffusion weighted images compared to the flare images. And this is herpes encephalitis in the right temporal lobe or the insular ribbon, and also in the frontal area. But you see in the diffusion weighted images, the restricted diffusion here and there. And of course, the low signal in the ADC map. A case of right-sided temporal lobe herpes encephalitis, and this is CT, T1, T2, flare, and restricted diffusion in the DWI with very bright signal in the temporal lobe. A case of acute cerebellitis in the flare images and in the diffusion weighted images, and you got bright signal in the DWI, meaning that there is diffusion restriction. Subdural empyema in the tentorial leaflet by T1 post contrast. You got collection with marginal enhancement, and you see another collection in the frontal falx. And in the diffusion weighted images, you got restriction here, there, and there. And of course, with decreased signal in the ADC map in all lesions, meaning that there is diffusion restriction. Another example of subdural empyema, and you see marginal enhancement of the bus located within the left side of the falx, and this is DWI showing bright signal, ADC showing low signal, meaning that there is restricted diffusion. Another example of subdural empyema, contrast enhanced T1 weighted image, T2 weighted image, DWI bright signal, ADC low signal, meaning that there is diffusion restriction. A fourth example of subdural empyema in the tentorium, T1 weighted image coronal post contrast with marginal enhancement, and here you see bright signal, low signal in the EDC, meaning that you have restricted diffusion. Then if I asked you, what do you think about this lesion? And you look to the T2 weighted image, you got bright signal, and the T1 post contrast, you got marginal enhancement. This may be an abscess, maybe a glioma. Look to the diffusion weighted images, and you got restricted diffusion, then you are dealing with abscess. Then what do you think about this lesion? In the flare image, you see the lesion T1 post contrast, marginal enhancement of non-uniform thickness. In the diffusion weighted image, you got low signal. In the ADC, you got high signal, means that there is diffusion free, and this is a glioblastoma multiforme. Then what do you think about this lesion? T2 weighted image, T1 post contrast, diffusion, and ADC. And that is right, this is a tumor because there is free diffusion except for the margin of the lesion, and this margin is restricted because it is of bright signal in the DWI and low signal in the D. Then this is known in cases of glioma and also in cases of metastatic deposits. But in order, of course, to differentiate between metastasis and the glioma, you should go to the history and the multiplicity of the lesions, as I have mentioned before. But diffusion weighted image cannot discriminate between metastasis and the glioma if it is solitary. I think I have mentioned in the lecture of spectroscopy that spectroscopy is very good here to discriminate between metastasis and glioma. And MS lesions usually show free diffusion, and the literature says that if there is a larger lesion or the lesions which enhance after injection of contrast may show diffusion restriction. A diffusion weighted image cannot differentiate MS from ADAM. In spite of that, ADAM is an inflammatory process which is expected to induce diffusion restriction, but ADAM in particular will show free diffusion. Lesions of ADAM will show free diffusion, and also lesions of MS will show free diffusion. Then here you see a lesion of MS which is well demonstrated in the FLAIR image. It shows some enhancement after injection of contrast, and the lesion is a little bit bright in the diffusion weighted image. May suspect that there is some diffusion restriction here. And these are MS plaques, and one of them, which is the bigger one, shows diffusion restriction here, bright in the DWI and black in the ADC. In cases of trauma, especially the trauma resulting in diffuse axonal injury, actually on MR images you may not be able to detect the lesions. Like this is an example. The lesions appear as petechial foci of hemorrhage, and this is the FLAIR image. Gradient images are very sensitive for detection of blood, like these foci. And in cases uh, of diffusion weighted images, the lesion may show diffusion restriction. And this is an example of a patient with diffuse axonal injury. The lesion is here in the splenium of the corpus callosum with bright signal here, and there is low signal in the ADC map denoting diffusion restriction. Of course, this should not be mistaken for the lesion in the splenium of the corpus callosum previously mentioned because of the history of significant trauma. Then you see multiple foci of low signal detected in the gradient images, and these foci usually represent blood, but also calcium may appear of low signal like this. This is a patient with motor vehicle accident. The CT scan showed minute foci of hemorrhage, and this is typical of diffuse axonal injury. And in the MRI, in the FLAIR image, you may see some of these lesions as bright foci, but in the diffusion weighted images, you see restricted diffusion in these areas with black appearance in the ADC map. Then in cases of dermoid and arachnoid, dermoid cyst will show diffusion restriction. Here is a lesion which is near to the cella. And this lesion in the FLAIR image is typically not of similar CSF signal, because arachnoid cyst will show CSF signal in the FLAIR image, but the epidermoid will not. And in the diffusion weighted images, the epidermoid will be bright while the arachnoid will be black. And this is another example of epidermoid cyst at the left cerebellopontine angle, low signal in the T1, high signal in the T2, intermediate signal in the FLAIR, and the bright signal in DWI denoting restricted diffusion. On the opposite, the arachnoid cyst will appear of low signal in the T1, high signal in the T2, and low signal in the FLAIR images. In the diffusion weighted images, you got black signal denoting free diffusion. Then what do you think about this cyst, which is located in the right cerebellopontine angle? The cyst appears of somewhat hypodensity in the CT scan, and this is FLAIR image. This is T2. And this is also FLAIR image, and this is T1 post contrast, and this is DWI, and here is the ADC map. Actually, it is well shown that the cyst shows diffusion restriction, and this is epidermoid cyst. And what do you think about this lesion at the cerebellopontine angle, which is a good location for epidermoid? But in the FLAIR image, the lesion showed low signal, and in the diffusion weighted images, it appeared also of low signal, and this is arachnoid cyst. Then cholesteatoma, and this is one of the values of diffusion weighted images, is to differentiate between cholesteatoma and otitis media. Otitis media will show diffusion free, while cholesteatoma will show diffusion restriction. Here you see bilateral cholesteatoma showing diffusion restriction on both sides. Thank you very much. Alhamdulillah Rabbil Alameen.